In terms of stress, I always think of stress as both a response within the brain and a response within the body. And I'm not alone in that belief, I think. We know that adrenaline, epinephrine, is released from the adrenals, but also from areas of the brain like locus coeruleus, so that there's this parallel effect of elevated states of mind, more alert, more focused on narrow locations in space and time. And the body is also prepared for action. I think this is what underlies the increased heart rate, the shaking in some cases, sweating. It's essentially a preparation for action. With PTSD, I often hear that some of the symptoms are more of the opposite end of the spectrum in terms of autonomic arousal, right? Things like dissociation, fatigue, kind of checking out, which I realize is dissociation, but things that are more akin to kind of parasympathetic, right? For those that don't know, the sympathetic parasympathetic represents the continuum of autonomic interaction. Sympathetic having nothing to do with emotional sympathy. It's all about fight or flight type responses, although at lower levels, it's what's responsible for us being alert here, but not in fight or flight. And parasympathetic being more of the rest and digest, even leading into sleep type responses. So, if somebody experiences a big stressor, a trauma, or chronic stress to the point where it becomes PTSD, is there a tendency for them to be more hypervigilant and have a startle response, to have their head on a swivel all the time looking for danger, or to be more dissociative, or can both sets of phenotypes exist in the same person?
Yeah. No, this is very interesting. While we're talking about the letters, let me say that a lot of people call post-traumatic stress disorder post-traumatic stress injury, not considering it a disorder, but considering it something that where our fight or flight mechanism, the autonomic nervous system, has been desensitized, and we need to regulate it again. And it's going to hurt. It's going to be painful. It's just like when you break your arm and go to the emergency room and it hurts to be placed back in place, but it's the cure, is what cures it. So a lot of people visualize it, and sometimes I do, as an injury rather than a disorder.
Post-traumatic stress injury.
Injury.
Interesting.
And so what happens? So this autonomic system gets activated. We have our fight or flight reaction. But what happens to a young kid? Because they're very little and they cannot fight. They're also very dependent and they cannot flight. So they're stuck. They're stuck there. So they freeze. They freeze, and that's dissociation. It's actually, during development, a healthy defense mechanism. But very much like a white blood cell, that's very helpful. If you have too much of it, you develop a leukemia. You can develop dissociative disorders if that's the only thing you have. But it does help children cope with some of these situations, pretending this is not real or this is not happening to me. It's the only thing they have left. And because this arousal system is so key in the development of these children, I thought that we should look at the hormone cortisol in the kids. And when I was a fellow doing my child psychiatry fellowship, I was seeing all types of kids with all kinds of issues. Some had ADHD, some had OCD, some had PTSD symptoms. But I was getting a lot of kids with notes from school saying, this kid has ADHD, please place on Ritalin, right? A stimulant medication. And I'm like, wow, the diagnosis has been made. There's already a treatment plan. What am I training here for? But in some instances, they were right. The kids had ADHD. But in most cases, what happened is that hypervigilance that you're talking about was being misinterpreted as hyperactivity. And the dissociation was being misinterpreted as inattentiveness. So the kids were getting a diagnosis that was not correct. Of course, there are other very complex cases where you have both ADHD and PTSD. Also, ADHD can put you at risk to develop PTSD because you're not as attentive as to what's happening in your environment. But there's definitely two different conditions. And it was that clinical observation that made me think, well, people don't know enough about PTSD, and certainly they don't know enough about PTSD in children. And we were having some research in adults around that time in terms of cortisol levels. David Spiegel, who you've had here, Rachel Yehuda at the Bronx VA, looking at PTSD in adults. But I said, how does PTSD look early on? What's happening in the hypothalamic pituitary adrenal axis that is responsible for secreting cortisol and regulate cortisol when these children are young? Because this is a new axis, is it already not working or is it working right? And so we did a number of studies that demonstrated that the normal circadian rhythmicity of cortisol was there. It was higher early in the morning, which we need to jump out of bed. And as the day progresses, it decreases. Very helpful. It goes up when we are stressed, like when we have lunch. After we have lunch, cortisol goes up, right? So that we can help manage the insult of digestion or whatever. And these kids were having those levels. But something was happening in a number of studies, and we noted that the pre-bedtime level was higher. We were measuring it at different times, in the morning, pre-breakfast, pre-lunch, pre-dinner, pre-bedtime. But it was the pre-bedtime level that wouldn't come as low as the healthy controls. It would remain high. And this was also important clinically because many of the symptoms these kids were happening at night. Enuresis, right? Bedwetting, nightmares, not sleeping deep enough, not sleeping long enough, fears. At that point, I felt, we don't know anything other than the cortisol pre-bedtime is elevated, right? Maybe they need it to be. Who knows? But I was concerned about the work by Sapolsky, right? And Bruce McEwen, his mentor, demonstrating the neurotoxicity that glucocorticoids can have in key areas of the brain, areas in the limbic system and the cortical system, which, interestingly enough, have a lot of glucocorticoid receptors. So then we decided to look at brain structure and brain function in youth with PTSD symptoms and see how this cortisol would relate to that or not. And we did that through MRI, magnetic resonance imaging.
Let's talk about cortisol for a moment. It's a topic that has not received enough attention in previous episodes of the podcast. I'm just going to summarize a little bit of what you said, and you'll tell me where I'm wrong. Cortisol starts to rise just before we wake up in the morning, assuming a good night's sleep, and peaks maybe, 30 to 90 minutes after waking. For you slow risers like me, probably a little delayed. By the way, the height of that peak and the steepness of the curve can be increased by viewing morning sunlight. We know this. Bright light increases that cortisol peak. It'll make you a better early riser. But in any case, typically the pattern then is that it rises through mid-morning and into the early afternoon and then starts to taper off to lower levels. And as you mentioned, we'll see bumps in cortisol post-meal. If there's a stressor, we get a disturbing text, we get a bump in cortisol. But these aren't huge peaks unless it's a big stressor, correct? And then by evening, cortisol levels in healthy individuals are typically low, and that allows for transition into sleep, among other things, allow for transition into sleep. But you said in these kids with PTSD, cortisol doesn't come down to low levels as much as it does in healthy individuals in the evening and nighttime. And that, I imagine, would lead to perseverating on stressors from the day. This kid was mean. I have a test tomorrow. Maybe any stressor becomes more intense in our mind and body, as it were. And that perhaps could lead to issues with quality or duration of sleep, which then could perpetuate this cycle. Do I have that correct?
Correct.
Okay. So has the direct intervention of just trying to suppress evening cortisol ever been done? I mean, certainly there are drugs that will do this. Has that approach ever been taken?
I thought about that when I had those high levels, but I felt that we needed to understand better. I think yes, that there were some attempts with some medications, and I don't think that led to anything in terms of helping those kids or just helping individuals in general that had high levels of cortisol because of traumatic stress. But nighttime, you're right. It is a time when basically we fall asleep because we let it go. And this kid's hyperarousability does not allow them to let it go. So if these levels are high, as I was finding, what impact are they having in brain development? And usually the younger you are, the more universally distributed receptors are. So glucocorticoid receptors could be anywhere at that point, but as we age, they become more localized. And the glucocorticoid receptors, and cortisol is a type of glucocorticoid, are more common in areas like the hippocampus and the prefrontal cortex, which I also found interesting because these areas relate to the symptoms, right, that many individuals with PTSD have.
Memory, anticipation of the future, problem solving, context-dependent problem solving, so on.
And even those attention issues that make them overlap with kids that have ADHD as well. So this frontal limbic pathway, the prefrontal cortex communicating with these emotional areas of the brain, including the amygdala, which is very close to the hippocampus, needed to be investigated in pediatric PTSD, and what I sometimes call pediatric PTSS, because post-traumatic stress symptoms. Because, as I mentioned, there's a group of kids that have post-traumatic symptoms, do not fulfill criteria for DSM-5 PTSD, but their function continues to be impaired. Sometimes that's because of comorbidity. There's a high incidence of comorbidity with anxiety and depression. So most of our studies that have looked at PTSD symptoms also look at the impact of the interventions that we're doing in anxiety and depression as well.